Good afternoon, everyone. It's my honor to have the chance to present here. Today, my topic is contrast enhanced ultrasound in biliary system. According to the clinical guidelines of EFSUND, CEUS in biliary system is composed of two parts, including intravenous and intracavity CEUS. The first one is intravenous CEUS. As we know, intravenous CEUS is able to evaluate the bile duct or gallbladder's microblood perfusion and therefore is useful in differentiating tumors from gallstone, depicting the tumor boundary and diagnosing post-transplant biliary caused by ischemia. In the clinical practice, before we perform intravenous CEUS, several preparations are necessary, including confirmation of indications and contraindications, informed consent, contrast-enhanced agents preparation, and side effect prevention. It should be noted that pediatric CEUS has still not been listed as indication by now, and cholecystemic shock and acute cholecystitis was not a contraindication for intravenous CEUS. Besides, a conventional ultrasound examination is essential to make an effective plan of CEUS. The bile duct, gallbladder, liver, and the pancreas are examined to detect and select the proper target of intravenous CEUS. The subsequent examination was aimed to diagnose the target mass and detect intrahepatic metastasis. To achieve this purpose, a CEUS planning should be made to select CEUS path, dose of contrast-enhanced agents, and the proper display mode. Let's look at one example of gallbladder's polypoid lesion. Firstly, intravenous CEUS should be employed to evaluate whether blood perfusion exists in this lesion. By FI and HI fusion mode, we could precisely locate the lesion, while the dual mode evaluate whether there is contrast and its level could be more clearly observed. In the venous phase, the whole liver should be scanned to detect potential intrahepatic metastasis. If there is washout lesion in the liver, dual display mode should be employed to evaluate the intrahepatic lesion in the second CEUS. As shown in the clear plan image, FI and HI fusion mode is more suitable for precise location, while dual mode is useful for evaluation of enhancement level. The detailed steps of intravenous CEUS are listed as follows. Select the proper CEUS, inject contrast-enhanced agent and start timing. 1.2 to 2.4 ml of Somerville was injected for convex probe and 4.8 ml for linear area probe. When observing small target, the probe and image plane should be stabilized in order not to miss the target. When observing large target, the probe should be slowly moved to have an overall view of the lesion. Observe for 5 minutes and stop clips. The second part of CEUS in biliary system is intracavity CEUS. By injection through the drainage tube or physiological sinus, the structure of the biliary tray could be clearly presented. Therefore, intracavity CEUS could be applied in presentation of the biliary tray and variations. Diagnosis and treatment of obstructive jaundice and detection of fistula between bile duct and other anatomical structures. Different with intravenous CEUS, diluted contrast-enhanced agent was used in intracavity CEUS. Before injection, the obstructed bile should be extracted first to reduce the intracavity pressure and prevent the bile from retrograding into the blood. The purpose of intracavity CEUS is displaying bile ducts trace and obstructive level. There are three commonly used display modes for intracavity CEUS. The first one is FI and HI mixture mode, which help the doctor to confirm the obstructive level. The second is the accumulation mixture mode, which significantly improves the continuity of observation. Another is the 3D display mode, which is useful in evaluation of anatomical variations because we can clearly observe the biliary tray in different angles. Compared to intravenous CEUS, diluted sonoview with saline was injected through PTCT tube or drainage tube. The remaining steps of intracavity CEUS is similar to intravenous CEUS. When performing intracavity CEUS, some tips should be kept in mind. Firstly, if the biliary tray was invisible after injection of contrast-enhanced agent, the injection pressure and dose should be considered and modified. Secondly, intravenous and intracavity CEUS could be combined and performed respectively when necessary. Lastly, when the intracavity CEUS finished, the injected diluted contrasting agent should be extracted from the tube. During the examination, the equipment setting is mostly the same between intravenous and intracavity CEUS, including MI, brightness, depth, focus, and image storage requirements. The difference of these two methods mainly lies in the display mode based on the different purpose. FI and HI dual and mixture was employed in intravenous CEUS, while FI and HI mixture, accumulation mixture, and 3D was employed in intracavity CEUS. Also, based on the different purpose of these two methods, the image interpretation has some difference. Intravenous CEUS is helpful in evaluating the micro blood perfusion of the target organ and should focus on the enhancement level, distribution of the perfusion, and washout of the biliary structure. In the venous phase, the liver should be scanned to detect intrahepatic lesions. By comparison, intracavity CEUS focused on the structure of the biliary tray and the obstructive location. After the CEUS examination, the CEUS report should cover the general information of the patients, conventional ultrasound, presentation, and details of CEUS. Let's look at the clips to describe the process of CEUS in biliary system. This patient is a 64-year-old male with jaundice and no pain for 2 months. The conventional ultrasound examination showed dilatation of left and right intrahepatic bile ducts and sudden interruption of the proximal lumen of the dilated bile duct, and gallbladder was atrophic. And then full blood flow in the right branch of the portal vein could be seen, but the blood flow of the left portal vein was not shown, and the spectral Doppler could only show the blood flow of the hepatic artery. A hypoechoic mass was faintly visible in the hilum of the liver, but the boundary was unclear. After the ultrasound examination, we had a preliminary judgment. There was a lesion in the hepatic hilum, which caused the bile duct to be blocked. Then, the next step was to perform a contrast-enhanced ultrasound examination. Firstly, contrast-enhanced agent was prepared. And injected through the peripheral vein. The intravenous CEUS examination was performed. The results show that the hilar lesion was rapid, circular enhancement in the artery phase and quickly washed out during the portal vein and delayed phases, which was consistent with the hilar bile duct cancer. Next, we had to ask, where was the location of the bile duct obstruction? PTCD was performed. After the catheterization was successful, the diluted contrast agent was injected through the drainage tube. It was observed that only the right intrahepatic bile duct could be shown, and left intrahepatic bile duct and the common bile duct were not displayed. This meant that the level of obstruction lied in the right hepatic duct. That's all. This case showed that how to perform the intravenous and intracavity CEUS examination, and we can detect the hilar bile duct cancer and destructive level. That's all. Thank you.
Thank you, Professor Zheng. No, then my Professor Zheng online. Why?
Good afternoon, everyone. Now we have another case to help us better understand the clinical application of CEUS in biliary system. My friend, this case is a 64 years old male with intermittent abdominal pain for 6 months and jaundice for 2 months. Laboratory showed that a slight elevation of transaminases and a biliary and significant elevation of EFSUND, which is presented by TPP,
CRP, and CA199. All these elevated. Yeah, 下一张. Next. And conventional ultrasound examination revealed that the liver, especially the caudate lobe, enlarged. 下一张. Intrahepatic bile duct dilated slightly, like this and this, and without pancreatic duct dilated. 胰腺的胰管并没有扩张. Next. Yeah, with the rooming functure, we can see that the hilar bile duct, like this, yes, it's all thickened in a symmetry shape. 肝门部胆管壁增厚，而且呈现一个对称的形状 ，resulting in a luminal stenosis. 管腔变窄 ，like this, luminal stenosis. 下一张。And we can see enlarged spleen, like here, enlarged spleen, and hilar lymphadenopathy. 肝门部淋巴结也有肿大，皮肿大。Yeah. Next, we can see MRR and MRCP. They reveal that hilar and upper part of common bile duct O was thickened, like this, the O thickened. 这是肝门部胆管壁有增厚 and the possibility of cholangiocarcinoma was considered by MR. Next, please, To have a definitive diagnosis, an intravenous CEUS was performed. A slide, we can see the hilar bile duct O like this thickened, and during the artery phase, we can see a slight enhancement of the hilar bile duct O was observed, but it's worth noting that the O of bile duct was continuous. 这个胆管壁是连续的 and the boundary with the surrounding liver parenchyma was clear. 它和周围的肝实质分界是清晰的 Please next. In the venous phase, ISO enhancement was observed. 它呈现了一个等回声在门脉期 Please next. So, what's your diagnosis of this case? Please scan this QR code. Tell me the answer. Yes. Mostly, most answer is A, cholangiocarcinoma. But before I tell the answer, we can see another results. Please next slide. These patients perform another examination. IgG4 was tested and reviewed an elevated level, and because we think this is IgG4 related cholangiolitis, so the diagnostic treatment was also given. Please next. After the 3 months, MRR showed the thickening bile duct O and bile duct tree resolved. We can see no bile duct dilated and hilar bile duct O resolved. Next, please. And also, the laboratory test results improved. We can see these results all improved. So, please next. So this case, its diagnosis was IgG4 related sclerosing cholangitis. Why this diagnosis is this? It's based on the following points. The thickening bile duct O and the biliary structure caused by that was the typical imaging feature of IgG4 related sclerosing cholangitis, confirmed by the significant elevated level of serum IgG4. we can see the hilar bile duct or thickened in a symmetry shape. This is very important. And next, we can, in the CEUS examination, the surrounding liver parenchyma was very clear. So we must we must pay in mind. Apart from this, the enlarged liver and spleen was also an inadequate evidence to support this diagnosis. Lastly, the effective diagnostic treatment further confirmed it. Thank you. That's all.